Welcome to episode 27 of the Pro PA podcast. I'm your host, Prof G, and today we're talking about obstructive sleep apnea, or OSA for short, a highly prevalent and underdiagnosed condition with significant implications for health and quality of life. In this episode, we'll explore what causes OSA, how it presents, and the steps to diagnose and manage it. I'll also share practical pearls to help you bridge the gap between book medicine and real-world clinical practice. Let's dive in. First, let's look at the kinder patho. What is obstructive sleep apnea? Well, obstructive sleep apnea, or OSA, is a disorder characterized by repeated episodes of upper airway obstruction during sleep, leading to hypoxemia, hypercapnia, and disrupted sleep architecture. And this obstruction occurs when the pharyngeal muscles relax, and this causes a collapse of the airway, particularly in the oropharynx. Now, there is kind of a cycle of obstruction. So the airway collapses, leading to patient waking up briefly to breathe, which leads to the airway opens, then sleep resumes, and then the airway collapses again. So they go through these cycles of sleep wake and trouble breathing. And this cycle can happen dozens to hundreds of times per night. Now, I recently got diagnosed with obstructive sleep apnea, and the main symptom that I was noticing in the morning was one, I snored really bad, which not all snoring means that you have OSA, but I was also not getting very restful sleep. So let's look at some of the risk factors. Anatomical factors are going to be the number one cause, and this is mainly obesity. Obesity is the most common cause. Excess fat narrows that airway up in the neck area. Also, a large neck circumference, so they say greater than about 17 inches in men and about 16 inches in women. Greater neck circumference is going to increase the risk of OSA. And also craniofacial abnormalities. So things like enlarged tonsils and other things like that can also put you at higher risk. Now, there are some lifestyle factors that can contribute. Alcohol use relaxes the airway muscles, so can increase the amount of OSA, as well as sedative use. So using things like benzos or sleeping aid medications might increase your risk of obstructive sleep apnea. Other risk factors include the male sex, age greater than 40 years, smoking, and a family history of OSA. Now, how do these patients typically present? Well, daytime symptoms are going to be excessive daytime sleepiness, and this is the most common symptom that we see. We can also see fatigue or difficulty concentrating. Patients also get a lot of morning headaches, and this is due to that built up of hypercapnia throughout the night. And this daytime excessive sleepiness can be falling asleep on your job at a red light. It can be pretty bad. Some nocturnal symptoms can be loud snoring. It's often reported by whoever shares the bed with the patient, so their partner, and gasping or choking during sleep. Also, witnessed apneas or pauses in breathing. Exam findings, we're going to notice obesity as the number one. So we're looking at a BMI greater than 30, enlarged tonsils or tongue, a crowded oropharynx, and hypertension, which is a common comorbidity with OSA. So, how do we diagnose OSA? Screening is going to be one of our most vital tools, and one of the validated tools that we like to use is the Stop Bang questionnaire. And the questionnaire questions are within those two words, stop and bang. So the S stands for snoring, when I ask the patient if they snore. T stands for tiredness during the day. O stands for observed apneas. P stands for high blood pressure. B stands for BMI greater than 35. A stands for age greater than 50. N stands for neck circumference greater than 40 centimeters. And G stands for the male gender. So there are higher scores on the Stop Bang questionnaire are going to correlate with increased risk of OSA. So this can be one of the first things that we do when we suspect our patient of having OSA. Definitive diagnosis is made through a polysomnography or a sleep study, and this is the gold standard for diagnosis. It's going to measure the apnea-hypopnea index, or the AHI. And so mild OSA is going to be 5 to 15 events per hour. Moderate OSA is going to be about 15 to 30 events per hour, and severe OSA is going to be greater than 30 events per hour. And when I think of a sleep study, at least when I used to study for my PANCE PANRE exam, I thought of having to go into a facility and put all these wires connected up to you and try to get some sleep. But nowadays, the polysomnography is actually really efficient for patients. They actually hook you up or send you home with a device that you can connect at home. And it's not a whole bunch of wires, just a few here and there, and it measures your sleep at home in the comfort of your own bed, which I think is probably more reliable in general. And this home sleep apnea testing is an alternative for patients without comorbidities so that we can measure the parameters in their home setting. Now, let's look at the management overview. So, number one, management is going to be lifestyle modifications. We want to encourage our patients to lose weight if they are obese. We want them to avoid alcohol and sedatives, especially before bedtime. And we'll also advise some positional therapy, so sleeping on your side and not on your back. Another thing that we can give our patients is positive airway pressure therapy, and this is CPAP, so continuous positive airway pressure. It's a device, and this is considered the first line treatment for moderate to severe OSA. Basically, what a CPAP does is it keeps the airway open by providing a constant pressure of air in between breaths. And there's also a BiPAP or a bilevel positive airway pressure that is an alternative for patients that are just intolerant to having a CPAP. There are also oral appliances that we can prescribe for our patients or that they can get from a dentist. And these mandibular advancement devices basically open up the bottom jaw, and they're considered not first line, and they are considered a treatment for mild OSA or patients that are unable to tolerate those CPAP devices. We also have some surgical options. These are reserved for more severe cases of anatomical abnormalities. We have the UPPP or the uvulopalatal and this removes excess tissue from the throat area. We also have these newer devices that are called hypoglossal nerve stimulation devices. They're implanted underneath the jawline and the neck, and they basically stimulate airway muscles during sleep. We also need to consider treating these comorbidities associated with OSA. So, we want to manage the hypertension, diabetes, and assess for cardiovascular risk. So, what are some of the complications of untreated OSA? Cardiovascular, so hypertension, atrial fibrillation, myocardial infarction, and even stroke. And metabolic, we can increase insulin resistance and actually precipitate type 2 diabetes. And neurocognitive, it can cause memory problems, depression, and even accidents due to drowsiness. So let's look at the book med versus the street med. So book med textbooks are going to emphasize the polysomnography as the diagnostic gold standard and CPAP as the mainstay of treatment. Weight loss and avoiding sedatives are recommended for all patients. Now, street med, in clinical practice, CPAP adherence is a major issue for patients because many patients struggle with discomfort and they're not very compliant. So, solutions like mask refitting and humidifiers can help. Also, the home sleep studies are increasingly popular for practical reasons, especially for uncomplicated cases. And many patients present with nonspecific complaints like fatigue, so screening tools like the Stop Bang survey are critical for recognizing OSA early. One other pearl that I want to mention here is that the CPAP devices, even with medical insurance, can be quite pricey as well as the oral appliances. So this is something that a patient's going to have to weigh for themselves, the risk benefit ratio for being able to even afford one of these devices. So that's something to consider as well. Now, some quick clinical pearls. Number one, OSA is the most common sleep related breathing disorder and it affects up to 25% of adults. So it is very, very common to see this in the clinic. CPAP is the gold standard, but patient education and support are likely to improve adherence. Number three, always screen for OSA in patients with hypertension, obesity, or daytime fatigue. Number four, severe OSA increases the risk of cardiovascular and metabolic diseases, making early diagnosis and treatment essential. And number five, the Stop Bang questionnaire is simple, yet effective screening tool for identifying high-risk patients. All right, now that we've gone through all that, let's go ahead and test our knowledge. So we have question 1. A 50-year-old male presents with excessive daytime sleepiness, loud snoring, and episodes of choking during sleep reported by his partner. He has a BMI of 36 and a neck circumference of 18 inches. What is the most appropriate next step? Is it A, prescribe CPAP therapy, B, refer for polysomnography, C, order a chest x-ray, or D, start lifestyle modifications only? I'll give you a few seconds. If you said B, refer for polysomnography, you are right. So, a polysomnography or sleep study is the gold standard for diagnosing OSA and is necessary to determine the severity of the condition before initiating treatment. Question 2. A 45-year-old female with newly diagnosed OSA has difficulty tolerating her CPAP machine. She feels claustrophobic with the mask and has stopped using it. What is the next best step? Is it A, recommend weight loss and avoidance of alcohol? B, prescribe a mandibular advancement device? C, refer to a sleep specialist for mask refitting and support? Or D, consider hypoglossal nerve stimulation? I'll give you a few seconds. If you said C, refer to a sleep specialist for mask refitting and support, this is the right answer. So, mask discomfort is a really common reason for CPAP noncompliance, and adjusting the mask or adding humidification can really improve tolerance before exploring other treatment options. All right, well, I want to thank you for joining me on this episode of the Pro PA podcast. I hope this has provided a clear and concise overview of how to recognize, diagnose, and manage this common yet serious condition. Stay tuned for the next high yield topic where we will continue to cover key clinical topics and panceprep essentials. Don't forget to follow the podcast and turn on notifications so you never miss a new episode. And remember, this is the Pro PA podcast, where future pros in medicine are made. I'll see you soon.